to you,
right.
Simon. Yeah.
Terrific, thanks. Okay, so I'd like to welcome everybody to today's MPCCC and Monash BDI Cancer Discovery Seminar Series. My name's Associate Professor Simon Chu, and I'm the Research Group Head of the Hormone Cancer Therapeutics Lab here at the Hudson Institute of Medical Research. I'd like to open today's seminar by acknowledging the traditional owners of the lands on which we join together from today, and respectfully acknowledge their elders, past, present, and emerging, as well as any members of the Aboriginal and Torres Strait Islander community gathered amongst us this afternoon. The Cancer Discovery Seminar Series is a community of scientific researchers, health professionals, and academics from across Victoria working within oncology. These seminars help to share the latest research activity across the partnership in Victoria as well as internationally, and to communicate new ideas and approaches to clinical care. Today's seminar topic is immunotherapy using combined anti-PD-1, CTLA-4, checkpoint blockade in rare malignancies, lessons learned from the CA209-538 and Outlook towards most circuit. We're lucky to welcome our guest speaker, Dr. Oliver Klein. Dr. Klein is a medical oncologist at Peninsula and Austin Health and a clinician-scientist at the Olivia Newton-John Cancer Research Institute with a long-standing interest and expertise in both laboratory as well as clinical cancer immunology. He's worked for 20 years in the field of cancer immunotherapy, initially conducting cancer vaccine research and subsequently participating in the first clinical trials using anti-CTLA-4 and anti-PD-1 antibodies in patients with advanced melanoma. So thank you, Oliver, for joining us this afternoon to present this seminar series, and I'll hand it over to you now.
Thanks, Simon, for the lovely introduction, and thanks for inviting me to talk. So, as Simon pointed out briefly already, so today I will just speak about two clinical trials we've conducted here, or we pretty much invented here at the Olivia Newton-John Cancer Research Institute, using combined checkpoint blockade in patients with rare malignancies. One study, the mouse circuit trial, is currently still ongoing, and I will give you some kind of preliminary insights in the study as well. So just to kick it off a little bit for the non-clinicians, is really on, and I understand it's a fairly busy slide, but where we up to with immunotherapy at the moment? So we, most of you will know that we pretty much use two separate group of agents targeting two different pathways on immune cells. So we have if you go on the left-hand side, you pretty much have the panel here, the anti-PD-1, PD-L1 axis. So we have a couple of monoclonal antibodies, nivolumab and pembrolizumab are the most well-known ones that target anti-PD-1 on T cells, on exhausted T cells, and we have the anti-PD-L1 antibodies, which impact on the same pathway, pretty much, however, blocking pretty much the molecule on the side of the tumor cell or the antigen presenting cell. And the well-known one is atezolizumab, most likely. And then we have a checkpoint CTLA-4, which we not clinically target so commonly. It's predominantly really in melanoma, in renal cell carcinoma, and more recently also in mesothelioma and lung cancer, but that's in combination generally with an anti-PD-1 antibody. And most recently now on the field of melanoma, once again, there's a new checkpoint, LAG-3 on T cells, and we target it in combination with anti-PD-1 as a combination treatment, not as a monotherapy. And this treatment really has just a role at the moment in melanoma. And if you see, pretty much immunotherapy is involved in standard treatment of many malignancies now. There's still a few cancers where immunotherapy is barely successful, gliomas, pancreatic cancer, most importantly also microsatellite stable colorectal cancer, so there's and most subtypes of breast cancer as well. But what you can see here, obviously, there's already a range of different malignancies where we use checkpoint inhibition, often in combination with chemotherapy or in combination with anti-angiogenic treatments or with multityrosine kinase inhibitors, for example, axitinib, lenvatinib in renal cell carcinoma. So if we really look for modalities we use currently in different types of cancers, we really have the pure checkpoint blockade, so either with an anti-PD-1 agent or in combination with a CTLA-4 blocker or a LAG-3 blocker. We have the combination with chemotherapy, or we have the combination with an VEGF inhibitor. And you can see there were quite a few failures over the last 10 years since these agents have been established in clinical practice. So we had negative trials in combination with IDO inhibitors. We had negative trials in melanoma with pegylated interleukin-2, so a cytokine that expands effector T cells. And the most promising next approach at the moment, at least from the melanoma field, is really combining anti-PD-1 blockade with personalized vaccines, with mRNA vaccines. And as you may know, there's already very promising early data in resected melanoma, metastatic melanoma. So that's really sort of the landscape of IO treatment currently across different malignancies. So why have we chosen combined anti-PD-1 CTLA-4 blockade for our studies? Because it's still seen as one of the most efficacious pure immunotherapy regimens. So you can see, as you will be aware, we believe, at least that's so the paradigm, that PD-1 blockade works in the tumor microenvironment. So you can see that here. So there's this interaction between PD-L1 on a tumor cell and the exhausted T cell that expresses PD-1 and inhibits pretty much the effector function of the T cell. And with blockade of this interaction, you unleash your cytotoxicity and the tumor cell is getting killed by the T cell. In contrast, or pretty much in addition, CTLA-4 blockade is thought to work predominantly in the lymphoid organs. So you have the interaction between your professional antigen-presenting cell that presents antigen to a T cell. And with the blockade of CTLA-4, you actually expand these T cells in your secondary lymphoid organs. So the idea is if you combine both agents together, you get some complementary positive influences on your immune system. And that's something which has shown, at least in melanoma and a few other cancers as well. So you can see here on the right-hand side on the upper panel, there's a Kaplan-Meier survival curve of a clinical trial in melanoma that was called the Checkmate 067 trial. It's a fairly long follow-up now, since a couple of years, more than 5-6 years now. And you can see the red curve is the combination treatment, and the blue curve is just to use an anti-PD-1 monotherapy by itself. And there is, in the long-term follow-up, certainly a difference, also quite modest difference between the combination and the monotherapy. Secondly, what's very interesting as well is that you can actually overcome resistance to anti-PD-1 monotherapy with combination treatment. So a patient that did not respond, for example, to nivolumab or pembrolizumab, you can rescue, at least in melanoma, and there's some limited data in renal cell carcinoma and some other cancers as well. You can actually rescue these patients with combined checkpoint blockade. What I should, however, point out, and many of you may be aware, is combination treatment is more toxic. There's a higher grade of immune-related adverse events, so a higher rate of autoimmunity. And interestingly, the dosing and the scheduling of the CTLA-4 antibody ipilimumab seems to impact on the toxicity. And we are not quite understanding at the moment why that's the case, why the dose range is impacting on toxicity, something we don't see with PD-1 inhibitors. You can dose them 10, 100 times higher, and you won't get a higher immune-related toxicity, different with CTLA-4 blockade. So to conclude is pretty much we use this combined checkpoint blockade because we wanted to investigate the most effective immunotherapy treatment in our trial cohort. And coming now briefly to rare cancers. So as many of you may appreciate, it's really an unmet medical need. Rare cancers are actually common. So if you look on the database, it's roughly 20-25% of all annual cancer diagnoses are due to rare cancers. So as a collective, they're fairly common. There's different annual incidences. It depends. One of the National Cancer Institute in the US definition is less than 6 cases per 100,000 population. That would, however, also entail some of what we would consider more common malignancies as well. most of the rare cancers we enrolled into our study would have an incidence around 1 to 2 per 100,000. Obviously, they're poorly studied as a sole tumor because there are not many patients around, and there's certainly no high-level evidence to guide the treatment decisions. And many of these patients are treated according to guidelines for more common malignancies that may arise from the same organ system. And not unsurprisingly, the outcome of these patients with treatment is fairly poor, and the survival is inferior to more common malignancies. On the pie chart on the right-hand side, you can see a little bit the spread across the organ system where rare cancers evolve. For the purpose of our trials, we really focused on 3 different subgroups: the gynecological rare cancers. So there were all malignancies other than high-grade serous ovarian cancer and endometrial cancer, as well as cervical cancer, because all these cancers have dedicated immunotherapy trials. In the gastrointestinal cohort, we focused as well as on neuroendocrine and endocrine tumors as well. If I move on then, so that was our first study, which was called the CA209-538. That was a trial that was initiated back in 2017, was a trial that initially was running around 3 sites, Austin, Peter Mac, and Monash. And then at the second part of the study, as we extended our trial cohort, it was also extended to New South Wales, to Westmead, as well as Border Medical Oncology. And the sponsor was, and the trial was initiated at the Olivia Newton-John Cancer Research Institute. So you can see we enrolled for this study 120 patients with rare cancers. Was pretty much 3 different cohorts, so upper GI cancers, gynecological cancers, neuroendocrine cancers. And we treated patients with the CTLA-4 antibody ipilimumab and this anti-PD-1 antibody nivolumab. And perhaps to point out, we used an induction regimen. So with these 2 treatments, sometimes what occurs is we use induction treatment. So you administer both agents at the beginning for 4 treatments. And then if patients have stable disease or no toxicity and a good response, you maintain this treatment response just with the anti-PD-1 and monotherapy by itself. Differently, in some of the trial schedules, for example, treatments, for example, in mesothelioma or lung cancer, you would use an ongoing 6-weekly schedule with lower doses. So in this patient population, we had the induction treatment. We used a 1 milligram per kilogram ipilimumab dose, which lowers the toxicity. So we know that roughly from previous studies that roughly a third of patients will develop some high-grade immune-related adverse events, which were well manageable in this trial. And unfortunately, there were obviously no toxic deaths to trial treatment. So that was the setup of the trial. There's a study design, and here you can see the tumor types. So once again, a whole spread of tumors. So you can see the neuroendocrine cohort, a whole range of low-grade, high-grade neuroendocrine tumors arising from the lung, arising from the pancreatic gland, GI tract, prostate, for example. And we had also a couple of patients with adrenal cortical carcinoma. Patients with small cell lung cancer were not allowed onto the trial because they had dedicated immunotherapy trials, and it's pretty much standard of care chemoimmunotherapy in small cell lung cancer now at this stage anyway. Gynecological cancer, as I pointed out, high-grade serous ovarian cancers, endometrial cancers, as well as cervical cancers were not allowed onto the study, but carcinosarcomas, for example, rarer forms of ovarian cancers were enrolled into the trial. And then the upper GI cohort was predominantly made out of biliary tract cancers, and there was certainly a reflection that 2 of the trial sites, so Westmead Hospital and the Austin Hospital, is a major referral center for liver transplants and liver cancers. So we had quite a large number of biliary tract cancers on this study, and a very rare form of GIST, who in fact had an excellent treatment response, and 1 patient with small bowel adenocarcinoma as well. So if you look on the treatment response, which was really very pleasingly to see, is On the left-hand side, obviously, what we call a waterfall plot. So once again, for the non-clinician, each of these bars represent a patient, and if the bar heads downwards, this represents some tumor shrinkage, and if the bar is going upwards, that indicates tumor increase and progression. And you can see a significant number of patients, really the bars trending downwards, and with a significant number of patients, roughly a third of patients actually achieving, as per definition, a partial response. So that means really the target lesions that were defined prior to therapy shrunk by 30% or more. And you once again can see that was really across the tumor range. So there wasn't a particular subgroup of patients or one basket doing better than the other. So the gynecological cancers, we had very deep responses, similar with neuroendocrine, but also with some of the upper GI cancers. And you can see here on the right-hand side, pretty much just a bar graph. Once again, you can see here the upper bars, the neuroendocrine cohort, the gynecological cohort, the upper GI cohort, and you can see a significant number of patients. So the patients colored in blue achieved an objective response, and a significant number of patients had also stable disease, so that around roughly 50% of patients would achieve a clinical benefit from their trial treatment. So that was very, very nice to see. Not unsurprisingly, and that's something which obviously sets immunotherapy using checkpoint inhibition apart from chemotherapies, that we know that responses in these patients often are durable. So you can see the quality of the response. So if patients achieved a complete remission, or if they achieved a partial remission, predicted their long-term outcome and their survival. And we have certainly at least 20%, 25% of patients. So just keeping in mind that this study actually started in 2017. So there's a significant number of patients that's still alive now, many years after enrolling into the study. You can also see there was a patient population which did really poorly. There was roughly 20 patients who did not make it to the first restaging scan. And it could well reflecting the fact that these patients had fairly advanced disease. However, we still investigate also the possibility of what we call a hyperprogression. So there is this phenomenon with checkpoint inhibition that there is, depending on tumor type and description, 10 to 15 to 20% percentage of patients treated with checkpoint inhibition that can obtain a rapid disease progression. And the question is obviously why that occurs. It seems like a negative impact on the immune system, on the tumor growth. Moving on now to the biomarker analysis. And I think that's obviously important for, if you talk about precision medicine or personalized treatment and personalized immunotherapy treatment, we're obviously lagging way behind the field of targeted therapy, where we have defined genomic aberration that we can target with chemical molecules. One of the goals of this first study was really also to get an idea from testing tumor samples, which were mainly fresh formalin-embedded tissue. So there were some difficulties really with the analysis. Testing also germline polymorphism, testing blood samples for lymphoid and myeloid cell abnormalities, as well as, interestingly, also baseline stool specimens to analyze for the microbiome. So that was part of the translational research for this trial. And the first piece of data I show you is really from the tumor mutational burden. So something many of you may be aware as well. So we know, and it's established now since a few years already, that as your number of non-synonymous mutations in the tumor increase, so like highly mutated tumors like skin malignancies that arise on the head and neck region, for example, cutaneous SCCs, microsatellite unstable tumors where the genomic integrity of the tumor is not enabled because there are deficits and there's defects in the machinery, that these tumors respond better to at least anti-PD-1 monotherapy than tumors which have a lower mutational burden. And there was, in fact, a study which was called the CA209-538 trial, which was a large international study enrolling many different tumor types, also rare cancers. And they treated patients with anti-PD-1 monotherapy using an antibody called pembrolizumab. And you could see that the objective responses in what they defined as TMB high, which was a cutoff of 10 mutations per megabase, that these patients had a significant higher response rate than the patients who had a tumor mutational burden of less than 10. So you could see the response rate was 30% versus 6.7%. There's a big debate after this study, obviously, what's the best cutoff for tumor mutational burden? What's the assay you use? There may be different outcomes with this as well. What we could see in our study population, which we published on the right-hand side, is really that at least the median tumor mutational burden is not differing if you look for objective responses, stable disease, or progressive disease. And if you look, actually, the majority of responders really have a low mutational burden, which is not surprising for the tumor types we enrolled into this trial. That's known from the literature that many of these cancers have a fairly low mutational burden. So how can we bring that together with the data, with the KEYNOTE-158 data? I mean, our trial is obviously much smaller than the KEYNOTE data set, so perhaps a larger number of patients would have changed it. And the other point is certainly that potentially combined checkpoint is able to reinvigorate an anti-tumor immune response in low immunogenic tumors, which may be required in these tumors compared in high immunogenic tumors. You might just need an anti-PD-1 monotherapy, but that's certainly something which needs to be further investigated. So what I want to point out, and which you could see on the previous slide as well, obviously, for example, you had here on the stable disease population or the progressive disease population, patients with really high tumor mutational burden, but they really didn't respond to treatment. And why is that the case? So it's really that high antigenicity may not really equal high immunogenicity. So you may have a tumor with a lot of mutational abnormalities, but the immune system may not see this tumor, and no anti-tumor immune response will be mounted in these patients. And what we did in the lab is we really investigated this tumor tissue of these patients further. This patient was a patient with a uterine serous carcinoma. And this patient really had, in fact, quite a lot of T cells in the tumor. So that's pretty much so these white bits here. However, what was evident is that these tumors lost class 1, so they couldn't present the antigen anymore. And secondly, there were also some regulatory T cells, so some T cells that dampened the anti-tumor immune response. On the other patient, in contrast, for example, this was a lady, once again, with a very high mutational burden. So you would expect there should be quite a few neoantigen and neoepitopes that could be recognized by the immune system. This lady had a complete lack of T cell infiltration. So there were no T cells in the tumor. There was quite a significant number of myeloid cells and macrophages. So one hypothesis could be in this patient, for example, that either no anti-tumor immune response was initiated, so no priming of T cells, or these T cells just not trafficking into the tumor, and potentially these myeloid cells actually preventing trafficking of T cells in the tumor. But that's something which is obviously just, some kind of hypothesis. But clearly, this tumor microenvironment in these patients looks quite differently, despite the high tumor mutational burden. So I guess the bottom line is high TMB is not necessarily predicting for a response to checkpoint inhibition. What we could see, however, and something which is obviously commonly done now these days, particularly in certain cancers like non-small cell lung cancers, that we know that PD-L1 expression can at least enrich for responders to a checkpoint blockade, and we could see this similar in our patient population. So if you increase actually the cutoff of the PD-L1 expression, in this case on tumor cells, we also did it with what we call a combined proportional score, where you not just measure PD-L1 on tumor cells, you also measure the PD-L1 on inflammatory bystander cells. The graph looked fairly similar. So you can see you enrich pretty much for responders with a higher PD-L1 expression. And what it just really indicates is that these are tumors that likely have a hot microenvironment. There's a lot of immune cells in the microenvironment, and it's easier for you to unleash this anti-tumor immune response with checkpoint blockade. Interestingly, there were also tumors which have very high PD-L1, and some of them actually did not necessarily had some TIL infiltration. So how can we actually bring that together with the lack of response to TMB. There's some preliminary evidence we have from some seromic and T-cell data we did that in our trial population, potentially tumor antigen, T-cell responses against tumor antigens were not directed against neoepitopes. They may have been directed against other antigens, for example, cancer testis antigens in this patient population. And it's still some work which is going on in the lab at the moment. So moving on to host factors is also something we know. It's not just the tumor, but we know more over, I suspect, over the last few years as well, that some host factors play an important role. So there might be some germline polymorphisms which predispose patients, for example, to autoimmunity. And they may also have a positive effect in terms of the benefit to immunotherapy treatment. But as you are well aware, there's a fairly rapidly moving field of microbiota and microbiome. So over the last few years, starting in melanoma and lung cancer, it was really evident that the makeup of the gut, with what kind of bacteria the gut is made up, can predict for response to treatment. And there's obviously also increasingly data that the exposure of patients to antibiotics prior to their therapy or early into their therapy could have detrimental effects on the response to treatments. And so we had collected in our patient population baseline stool specimens. So just before patients went on trial, they gave a stool specimen, which was pretty much frozen down. And one of our postdocs and a current PhD student at the Sanger Institute took these samples and analyzed this. And he was actually, and it's something he's just submitting a manuscript for that. He's actually be able to identify a signature of 22 gut microbiota, which predicted for response to treatment. And he's actually validated this data set also in external manuscript or in data sets that are available at the moment, particularly from most of these data sets are available for melanoma patients. So which is very interesting. And he could also show that these microbial signatures are distinct for combined checkpoint blockade versus anti-PD-1 monotherapy. And obviously at the moment, it's still not very well understood how the gut microbiome impacts on these responses. I mean, there might be effects on myeloid cells. There's some data, most recently, I believe, about increasing immunogenicity of cancer by increasing class 1 expression with metabolites that are released by this microbiota. But that's obviously certainly very interesting data that Ash generated there. So now moving on to the current trial. So that was really the study we based the current study on, which is called CA209-538, or it's also called mouse circuit, because for this trial, we partnered with the mouse program. And what's exciting that pretty much for all of these patients, we will not just have outcome data for combined checkpoint blockade, we will really also have matching genomic data using the mouse genomic tumor panel, the TS500 assay, which potentially will give some interesting ideas what oncogenic pathways may facilitate successfully an anti-tumor immune response versus what pathways may lead to resistance to anti-PD-1 to combined checkpoint blockade. So you can see it's an ongoing study. It's actually an Australia-wide trial. We're a little bit higher than that. So I think it's 195 patients enrolled at the moment out of 240 patients. We have 4 tumor cohorts these times. So we really analyzed the data from the first trial and really identified the tumor types that were most responsive to therapy. In the neuroendocrine tumors, that were really the atypical bronchial carcinoids, a rare form of a neuroendocrine tumor of the lung. The high-grade cancers, so none of the low-grade cancers really responded to checkpoint blockade in the first trial. So really neuroendocrine carcinoma and grade 2 neuroendocrine tumors. In the biliary cohort, we identified really the responders in the intrahepatic cholangiocarcinoma and the gallbladder. Gynecological, not surprisingly, clear cell cancers. There's already quite a few data out from trials in the space of epithelial ovarian cancer that clear cells respond much better than serous cancers to checkpoint blockade. And then we've seen, surprisingly, also 3 out of 5 responders in the first study with uterine leiomyosarcoma, a cancer type that has, based on smaller trials, deemed to be quite unresponsive, at least to anti-PD-1 monotherapy. And excitingly, we excluded a 60-patient cohort of microsatellite unstable mismatch repair protein deficient cancers, some cancers which we obviously know are highly immunogenic. We know their success with anti-PD-1 monotherapy, but we don't have a good idea if combined checkpoint blockade actually can lift this bar up even further. We excluded colorectal cancer patients in this trial because anti-PD-1 monotherapy is standard of care for these patients already in the first line and available on the PBS. If you go to the right-hand side, you see pretty much the same trial schedule like with the first study, combination treatment of the 2 agents for 4 doses, and then for 2 years if patients had an ongoing response and no toxicity with nivolumab, so something which is well established across different tumor types like melanoma, kidney cancer, and so on. And patients obviously every 3 months, every 12 weeks would be scanned for treatment response. That just outlines you where the trial sites are. So it's really a truly Australian-wide trial in the meantime. I think what we're missing is just the Northern Territory. More recently on board came Tasmania with the Royal Hobart Hospital. And we, in the meantime, have also a New Zealand site with the largest hospital in New Zealand, Auckland Hospital, participating on the study as well. And that's also reflected in the enrollment, which is very good at this stage. So perhaps, and that's, so the last few slides I use really what's very interesting, and I think where we can learn quite a bit about checkpoint inhibition is in these cancers, which we call microsatellite unstable cancers. So we had in the first treatment cohort, so all 120 patients were tested for mismatch repair protein deficiency or microsatellite instability, and you could see there were 3 patients that were unstable. There were 2 patients with adrenal cortical carcinoma. 1 patient subsequently actually was diagnosed with a Lynch syndrome, so like a germline mutation in one of the mismatch repair protein genes. And 1 patient had a uterine carcinosarcoma, and you can see all 3 patients had very good responses. In fact, all 3 patients are alive now between 4 and 5 years, and both all 3 patients had pretty much a complete remission to therapy. So very effective treatment in these patients. Interestingly, if we looked in the tumor of all these 3 patients, none of them had a PD-L1 expression, and there were no tumor-infiltrating lymphocytes. So, which makes you think that the combined checkpoint blockade at least may not work in the tumor microenvironment. So it may actually initiate an anti-tumor immune response in secondary lymphoid organs, where it's then unleashing T cells or expanding T cells, and these T cells then traveling to the tumor and mounting an anti-tumor immune response subsequently in the tumor. So this observation we really took in the current study. So we really said, look, 60 patients slots will be dedicated to microsatellite unstable cancers. And as I said, it's certainly a very interesting tumor agnostic clinical model to study cancer immunology because these cancers are so highly immunogenic. Just to remind everyone, what is this actually microsatellite instability? So we have different DNA repair machineries to keep the integrity of our DNA, our genomic material, and there's pretty much one machinery, the mismatch repair protein machinery, which uses 2 protein complexes, generally MSH2 and MSH6, and they come as pairs, and MLH1 and PMS2. And if you have a mutation either somatically or in the germline in one of these genes, then you lose this ability of repair, and you actually develop small nucleate variant mutations, but also some small deletions. And this creates this more immunogenic appearance of these cancers to the immune system. We should point out MLH1 obviously is something that can also be methylated. So you can have a promoter methylation in MLH1 that also leads to a loss of MLH1 and PMS2 in microsatellite instability. And there's some data suggesting that the outcome to immunotherapy may differ based on the underlying mechanism of microsatellite instability. There's some data from endometrial cancer arising, but very small numbers of patients. This trait is something which occurs across all tumor types, but you can see there are obviously certain tumors which are enriched for microsatellite instability. We talked about the colorectal cancer, that's the second bar here. The rectal cancer is the fourth bar. So we know that these treatments are well established in these patients. So if you're presenting with stage 4 with metastatic MSI colorectal cancer these days, or since at least a year and a bit, you're getting treated with pembrolizumab, with anti-PD-1 monotherapy, and you're not getting treated with chemotherapy treatment. However, there's other fairly frequent microsatellite stable cancers. So you can see endometrial cancer, for example, that's the highest bar. You can see here gastric cancer is the light blue bar. Adrenal cortical carcinoma, you can recall we had 2 patients on the first trial which had a complete remission to therapy, and a whole range of different types of cancers. So, for example, on the current study, we have a breast cancer patient, a prostate cancer patient. Both of these patients have microsatellite unstable cancers, but obviously common or very frequent tumor histologies. And once again, that's the graph or the figure I showed you beforehand is really that this microsatellite unstable cancers cluster very high in terms of response to anti-PD-1 monotherapy. And the reason for that is they have a high mutational burden. They look very abnormal to the immune system. But what you should see, and you can see that on the trial data here, once again, KEYNOTE-518, a study I mentioned before, which used single-agent anti-PD-1 monotherapy, demonstrated in this cohort of patients in these microsatellite unstable cancers, obviously a fairly high efficacy. Nevertheless, you can still see there's a significant number of patients who doesn't respond to their therapy. And if you look in the long-term follow-up, there is this patient population who has primary resistance, so they don't respond. They have progressive disease on the first restaging scan. However, then there's also this patient population with the slow drop of the curve that develop over time acquired or secondary resistance. And you pretty much end up, this study, that's not the most up-to-date publication, but I think this study has now a follow-up from 5 years. And you have a quarter of patients that is in complete remission or in a very good partial remission 5 years down the track. So there's certainly a quarter or a little bit more of patients who have long-term benefits, if not even be cured by their advanced malignancy. So if we look in our data set, so that's a very preliminary, it's actually, unfortunately, I should have updated it for today. So we have in the meantime, I believe, 40 patients in this basket, in the 60 patient basket of MSI non-colorectal cancer patients. And you can see the majority, not unsurprisingly, are made up by endometrial cancers because that's the highest frequency, carcinosarcoma, cholangiocarcinoma, bladder cancer, prostate cancer. As I said, this patient is actually not reflected here on their waterfall plot. So the prostate cancer patient has a complete remission in the meantime. Breast cancer patient has a very good partial response. And you can see that reflected here on a very preliminary waterfall plot with the vast majority of patients really responding to treatments. So the really exciting fact is that we really get from the most program our genomic data set as well. So we get a mutational burden. We actually get the information if there is microsatellite stability also discovered, if these patients are getting diagnosed with mismatch repair, protein deficient cancers, if that also translates in microsatellite instability based on the genomic testing. You can see here there's a whole range of genes which I just listed that are of interest in this kind of MSI cohort. So you can see that, for example, in this patient, you have a lot of negative factors. So this patient, for example, didn't respond to treatment, a patient with a pancreatic cancer that had been MSI high, so microsatellite unstable. So you would expect that that should be a patient who should respond very well to treatment. Sorry, it was a duodenal cancer. And the patient hasn't. And the question, why is that the case? So number one is the mutational burden potentially was on the lower side, despite the microsatellite instability. So I mentioned to you more than 10 we would normally see. This patient had just 12.6. But more importantly, the patient had a deletion of or inactivating mutation in beta-2 microglobulin, which leads to a loss of class 1 expression, so an immune evasion mechanism. The patient had also a P10 deletion, which leads, and we know that P10 deletions are detrimental to outcomes in anti-PD-1 monotherapy treated patients. So activation of the PIX3 pathway is of detriment to the outcome to immunotherapy in these patients. And also, for example, this patient had an inactivating mutation in the gamma interferon type 1 receptor. And we know that gamma interferon is one of the major effector cytokines in the anti-tumor immune response and checkpoint blockade as well. So this is ongoing work. So we really try to tease out, number one, if we get a signal in this patient population that combined checkpoint is better than anti-PD-1 monotherapy, but also really number two, in the patients who didn't respond to treatment, can we really pin down what the actual reason was why these patients did not respond, despite the fact that they had such an supposedly highly immunogenic cancer. And that's what I will end up with, and just acknowledge pretty much. So we have our trials team that run the first trial. So that we're really across a couple of sites, Peter Mac, Monash with Ben Markman, and then the sites in New South Wales. We have the Research Institute. We have our tumor lab that does most of the translational research work. And I might just stop with that. Thank you. Thanks for the attention.
Fantastic, Oliver. Thank you so much. What a fascinating journey that you've taken us through. Really interesting projects and clinical trials. So I'd like to open up for questions. Perhaps I could start with one. I'm sorry, I may have missed it. Do patients, or do they develop resistance to the combination treatment?
They certainly do, Simon. So obviously, I mean, we would argue from the first study, obviously, I mean, we had an objective response rate in the evaluable population if we take the hyperprogressors away from 30 bit. So you could argue some had stable disease, half of the patient would not develop an treatment response. So you have 50% have primary resistance, and another certainly a significant number of patients developed subsequently secondary resistance, so progression after initial response to therapy. Yeah. But I should point out many, and that's something we obviously see in more common malignancies like melanoma as well, or renal cell carcinoma. Many patients who have really deep responses will have these responses for a very long time. And I mean, it's always a big word in advanced malignancies, obviously, but some of these patients may be even cured by their cancer. So I see actually in our clinic here at the Austin still 3 of these MSI patients, and we stopped scanning them because it's 5 years now since they are pretty much in a response. Yeah.
Any questions from the audience? Either unmute yourself or put it in the chat. I've got another one, and that's regarding the microsatellite instability, which is really interesting. What about going to, say, the DNA damage repair, sort of perhaps also thinking about PARP inhibitors? And so
yeah, exactly.
Is that an area that...
Yeah, exactly. That's a very good question, Simon. I mean, there's obviously, as you might be aware, there's many trials now combining PARP inhibitors with anti-PD-1 monotherapy as well in this patient population of BRCA/NES cancer. So like really in this double-stranded DNA repair pathway abnormalities. I think it comes down to potentially similar scenarios that you might get a more immunogenic tumor visible to the immune system. I mean, obviously, if we really talk about the mutational burden in these patients with BRCA abnormalities, they're significantly lower than with MSI. Yeah, but we also know with microsatellite instability, and something really I wasn't aware much either, because we obviously, I mean, as clinician, we focused on microsatellite instability really just for colorectal cancers, and we did the staining just for colorectal cancers, is that many of the non-colorectal cancers have a typical staining pattern. So you normally, what you would get is on IHC, a combined loss of MSH2 and MSH6, or you get a combined loss of MLH1 and PMS2. In this more uncommon cancers, or in the non-established MSI cancers, you often get some kind of loss of a single protein. So isolated PMS2 loss, for example, or isolated MSH2 loss. And that not necessarily on a genomic level correlates with microsatellite instability. So that there's not 100% match between mismatch repair protein deficiency and microsatellite instability. Yeah, which is something interesting to see, because that may also influence, obviously, response to treatment. And some of the atypical staining pattern patients may have a lower mutational burden, for example, as well. Yeah.
Questions? All right, maybe one more from me as a self-interest. The two granulosa cell tumor patients that you had in your original trial, do you know how they responded?
They didn't respond, Simon. Yeah,
right.
No, they did both reasonably poorly. Yeah, none. Yeah, they didn't respond.
Okay.
Yeah,
that's interesting. Yeah. I would have thought they wouldn't have. Yeah. Okay. Yeah. All right. Well, if there are no questions from the audience, then it's my great pleasure to really thank you very much, Oliver. It was a wonderful presentation. Really enjoyed it. Learned a lot. And I'd like to thank you for joining us this afternoon. And I'd also like to thank all in the audience for attending online.
Excellent. Thanks, Simon. Thanks for the invitation. Bye-bye.
Thank you.